Okay, now we're moving on to the bisecting technique on chapter 18. Going over some of the learning objectives, we'll discuss the key terms associated with bisecting technique. We'll state the rule of isometry, the basic principles of the bisecting technique, and illustrate the location of the receptor, tooth, imaging bisector, central ray, and the PID. We'll list the beam alignment devices and receptor holders that can be used with the bisecting technique. We'll describe the receptor size used with the bisecting technique, the correct and incorrect horizontal angulation, the correct and incorrect vertical angulation. We'll state each of the recommended vertical angulation ranges used for periapical exposures, and we'll state the basic rules of the bisecting technique. We'll describe patient and equipment preparations necessary, the exposure sequences used for 14 PA receptor placement. Um, we'll describe each of the 14 PA receptor placements recommended for use in the bisecting technique, and we'll list the advantages and disadvantages of the bisecting technique. The purpose is to present basic concepts, to describe patient preparation, the equipment that you'll need, and the receptor placement procedures used. Also to describe the advantages and disadvantages of this technique, as well as some helpful hints. Now, the American Academy of Oral and Maxillofacial Radiology recommends the use of a paralleling technique for intraoral exposures because the bisecting technique sometimes can cause errors with angulation and distortion. But once you get accustomed to it and you learn more about how the angles work, and after you, of course, take so many of these bisecting exposures, it will become so easy, or you'll become so accustomed to it that it'll become like muscle memory, and you'll end up being faster at it. And that's something that you can't get with a paralleling technique because everybody has different anatomy, and sometimes using those rings, um, it doesn't always work with everybody's anatomy. So just keep that in mind. All right, some basic concepts. So the bisecting technique is just another method that can be used to expose PA images. So the bisecting technique is also known as a bisecting angle technique or bisection of the angle technique. Some key terms that you'll want to know, they are in the book starting on 175 to 176, are angle, bisect, what a bisect is or what it means to bisect, what a triangle is, what an equilateral triangle is, as well as a right triangle, what a congruent triangle is, what a hypotenuse is, what does isometry mean, the long axis of the tooth, as well as a central ray. So the bisecting technique is based on a simple geometric principle known as the rule of isometry. The rule of isometry states that two triangles are equal if the triangles have two equal angles and share a common side. This geometric principle is applied to the bisecting technique to form two imaginary equal triangles. The bisecting technique can be described as follows. So if you'll look over on figure 18-5, and this is on page 177, all of this stuff will make sense if you're looking at that picture. So go ahead and turn to your book and take a look at figure 18-5. So first, the receptor is placed along the lingual surface of the tooth, and the plane of the receptor and the long axis of the tooth form an angle at the point where the film contacts the tooth. So right where that film meets the tooth, that forms that angle. An imaginary bisector bisects or cuts in half the angle formed by the receptor and the long axis of the tooth. The central ray is directed perpendicular to that imaginary bisector such that it creates a 90-degree angle. And the two imaginary triangles that it makes are right triangles, which are congruent. So this is also known as the BAI, which is the bisecting angle instrument technique or short cone technique. In the bisecting technique, beam alignment devices or receptor holding devices may be used to position and stabilize the receptor. And beam alignment devices are used to position the receptor, and aiming rings allow for easy alignment of the PID. They are recommended because they eliminate the need for the patient to stabilize the receptor. And these, what these look like are the Brin BAI system, and it almost looks like a stabe, but it's plastic. And there's a picture of one on figure 18-6 on page 177. And this is on figure A. That is what a RIN BAI system looks like. It just looks like a stay, but it has some graduated steps where the patient bites down, and this will form that bisecting angle. Also, the receptor holders that are used to position the receptor in the mouth and maintain it in position during exposure include the stay bite block, which we've probably seen in class, as well as the Wren snap array holder. The BAI instruments include metal indicating arms. We may have those in class. It's just it makes sure that the angle is bisected. They're a little different from the parallel angle rings that we had before. Those ones are designed to keep the PID parallel with the sensor or the receptor, which isn't what we want, or what we don't want in the bisecting angle technique. So the size 2 receptor is traditionally used for this type, for all the periapical projections with the bisecting technique. In the anterior region, a size 2 receptor is always placed with the long portion of the receptor in a vertical or upright direction. In the posterior region, a size 2 receptor is always placed with the long portion of the receptor in a horizontal or sideways direction. So vertical direction is upright, horizontal direction is sideways. In the bisecting technique, the angulation of the PID is critical. Angulation is a term to describe the alignment of the central ray of the X-ray beam in horizontal and vertical planes. When a receptor holder without an aiming ring is employed, you must be able to determine both horizontal and vertical angulations for each exposure. That may seem a little daunting, I know, but like I said before, as you get better at it with practice, you'll notice that a lot of these angles are the same, and then it all becomes muscle memory at the end. Horizontal angulation refers to the positioning of the PID and the direction of the central ray in a horizontal or side-to-side plane. With correct horizontal angulation, and if you look on page 178 on figure 18-8, we can see that the central ray is directed perpendicular to the curvature of the arch and through the contact areas of the teeth. On figure 18-9, right below that one, we can see what an incorrect horizontal angulation looks like. And in that angulation, we would end up with overlapped contact areas. And retakes would be necessary if there are any overlapped contact areas as we know. Vertical angulation refers to the positioning of the PID in a vertical or up and down plane. The correct vertical angulation results in a radiographic image that is the same length as the tooth. If you look on figure 18-11 on page 179, those motions of the PID are what we refer to when we talk about vertical angulation. An incorrect vertical angulation results in a radiographic image that is not the same length as the tooth. And the measurement of the vertical angulation is marked on the outside of the tube head. So if you have foreshortened images, foreshortened images refers to images that appear shortened, and this results from excessive vertical angulation. Elongated images refer to images of the teeth that appear long, and this results from insufficient vertical angulation. Always remember that when the open end of the PID is pointing downward, the PID has a positive angulation. And when the open end of the PID is pointing upward, the PID has a negative angulation. These are things that you'll want to understand if you're going to be using the recommended vertical angulation, which is listed here. So this is a table, table 18-1, which is also on page 179. It shows all the recommended vertical angulation ranges for this technique. And these are all just recommended vertical angulations. I want you to understand that there are some instances where, for example, canines for maxillary teeth are going to be less than 45 or maybe even more than 55. So these are good starting points to kind of get yourself acclimated with all the angles. But once you have gone through the ranges of all these recommended angles and it's still not giving you the correct image that you're looking for, just know that sometimes we may need to go outside of this box and just really look at the angles in our patient's mouth and figure out where that bisecting angle is, and then adjust your PID accordingly. So there are 5 basic rules that should be followed when using the bisecting technique. First, the receptor placement must be positioned to cover the prescribed area of the tooth to be examined. The receptor position must be placed against the lingual surface of the tooth. The occlusal end or the incisal end of the receptor must extend approximately 1/8 of an inch beyond the incisal or occlusal surfaces. The apical end of the receptor must rest against the palatal or alveolar surfaces. With vertical angulation, the central ray of the X-ray beam must be directed perpendicular or at a right angle to the imaginary bisector that divides the angle formed by the receptor and the long axis of the tooth. With horizontal angulation, the central ray of the X-ray beam must be directed through the contact areas between the teeth to avoid any overlapped contact areas. With receptor exposure, the X-ray beam must be centered on the receptor to make sure that all the areas of the receptor are exposed. If this isn't done correctly, the center of the X-ray beam results in a partial image or a cone cut. So foreshortening occurs when there is excessive vertical angulation. Elongation occurs when there is insufficient or not enough vertical angulation. Step-by-step procedures for the exposure of PA images using the bisecting technique include patient preparation, equipment preparation, exposure sequence for receptor placement, and as well as the receptor placement for the bisecting technique. So for patient preparation, so after completion of all infection control procedures and preparation of the treatment area and supplies, the patient should be seated. After seating the patient, you must prepare the patient before the exposure of any receptors. And then after the patient preparation, all the equipment must be prepared. And then when using the bisecting technique, you want to use an order for the PA receptor placements and exposures, and you must follow this order. You should also have an established routine, and this will help prevent errors and help you use your time more efficiently. Okay, again with patient preparation, just make sure that when the patient is seated, they are upright and both arches of their mouth should be parallel with the floor. Also, explain the procedures to your patient. Adjust the chair so that it is a comfortable area for you to work. Adjust the headrest to make sure that their chin or their occlusal plane is level with the floor, and then place and secure the lead apron with the thyroid collar. Also, ask that the patient remove any eyeglasses and any objects from the mouth, like any dentures, any partials, any piercings, or anything like that. Next, you'll want to set the exposure control factors, and this is the kilovoltage, the milliamperage or MA, and the exposure time. And we'll do this on the X-ray unit according to the recommendations of the receptor manufacturer. If the beam alignment device or a receptor holder is used, you'll want to open the sterilized package containing the devices and assemble devices over a covered work area. So some exposure sequence for anterior placements. You'll always want to begin with the anterior teeth. This is the canines and incisors. And you'll do this for the following reasons. First, the more tolerable anterior placements allow the patient to become more accustomed to the beam alignment device, and the anterior placements are less likely to cause the patient to gag. So we'll begin with the maxillary right canine tooth, and we'll expose all of the maxillary anterior teeth, and we'll end with the maxillary left canine. Then we'll move down to the mandibular or lower arch. And we'll begin with the mandibular left canine, and we'll expose the central anterior teeth, and then we'll finish with the mandibular right canine. After anterior exposures, the posterior teeth, which include the premolars and molars, are exposed. In each quadrant, always expose the premolar receptor first and then the molar receptor. The reason for this is the premolar placements are easier for the patients to tolerate, and premolar exposures are less likely to make your patient gag. So we'll begin with the maxillary right quadrant, then we'll move to the lower right quadrant, move over to the upper left quadrant, and then finish with the lower left quadrant. In each quadrant, we want to expose the premolar receptor first again, and then the molar receptor. So here we're just talking about receptor placement, and this is the specific area where the receptor must be positioned before the exposure. And this is dictated by the teeth and all the surrounding structures that must be included on the resultant radiograph. So if you look over to figures 18-15 as well as 18-16 on page 184, this is just illustrating what it is that I'm talking about here. Just giving you a picture of all the teeth that need to be included for each exposure. For anterior placement, for anterior placement, we'll start with the maxillary canine exposure. We'll then do the maxillary incisor exposure, and then the mandibular canine exposure, as well as the mandibular incisor exposure. So there will be 2 canine exposures on top, 1 incisor exposure on top, 2 canine exposures on bottom, as well as 1 incisor exposure. So just remember, anterior receptors are always placed vertically with the white side of the film facing the teeth, and then always center the receptor over the areas to be examined, just so that you don't end up with any missed receptors, which will give you something called a cone cut. Okay, so for the posterior placement, we'll end up with 2 maxillary premolar exposures, 1 on the left, 1 on the right, 2 maxillary molar exposures, 1 on the left, 1 on the right, and then 2 mandibular premolar exposures and 2 mandibular molar exposures. Always remember the posterior receptors are always placed horizontally. The primary advantage of the bisecting technique is that it can be used without a beam alignment device when the anatomy of the patient precludes the use of such device. So that means that they have a shallow palate, they have bony growths like mandibular or maxillary tori, or they have sensitive mandibular premolar areas. And this can be because of gum disease or other conditions which make these areas sensitive. All right, as always, if you have any questions, feel free to email me or of course, ask me in class. All right, thanks for listening. We'll talk next time.